Hey guys, this is Andy Johnson. Stephanie Clark and I will be presenting to you patellofemoral pain and discuss things about management for this condition. Here are the objectives. Main things: we will briefly review the anatomy of the patellofemoral joint. We'll discuss initial evaluation considerations along with some differential diagnosis things to consider. We will talk about interventions and management options, and these will all be based on the best evidence out there at the moment. And of course, we're going to review that literature for patellofemoral pain. Here is a picture of the anatomy. I don't need to go into details for you guys. You all know your anatomy. Just realize there are a lot of different structures attaching to this area. So a lot of different things that could be causing pain in the anterior knee specifically, so make sure you consider all these things during your evaluation. Just a quick review on the kinesiology and function of the patellofemoral joint. Two main functions of the patella itself. One, it increases the moment arm of the quadriceps tendon, also reduces the contact forces in the patellofemoral joint as well as the tibiofemoral joint. And we all know just the kinesiology. The patella glides superiorly when the knee is extending, and then it glides inferiorly when the knee flexes. During this time, the patella must track in the femoral groove in between the femoral condyles. This tracking is very important. If it's not tracking properly, then it can cause abnormal stresses in the knee, then of course causing pain. Diagnosing patellofemoral pain. There's no specific standards for diagnosing for this. However, there are definitely some clinical things we need to pay attention to that'll help lead us in this direction. Number one, of course, is just the location of pain. It's typically either parapatellar or retropatellar. The presence of lateral patellar tilt is very indicative of a possible patellofemoral syndrome. Also, if you can reproduce symptoms with going downstairs, squatting, prolonged sitting, and or running, it can also indicate patellofemoral pain. Then, of course, if there's the absence of a more probable cause for the patient's knee pain. Just a little etiology. Definitely more common in young females, especially young female athletes. The typical mechanism of injury is not related to one specific event, so it's typically not traumatic. It's more of a repetitive in nature over time. Some of the common causes will include high impact activity, such as your running and jumping. Happens a lot in your basketball players. Repetitive activity, stairs, walking on uneven terrain. And then also, again, this is more common with females, but a predisposition to poor patellar alignment or the increased Q angle starting at the hip. And you can see the picture there to the left. Here are some things to consider for differential diagnosis for patellofemoral pain. One, the lumbar radiculopathy, especially the L2 to L4 range, is going to refer pain to the knee. So make sure as you're doing your evaluation, you are ruling out any type of radic symptoms from the lumbar spine. Of course, the hip joint can refer to this area, and Stephanie will talk a little bit more about the role the hip plays in patellofemoral pain. Definitely a lot of different trigger points that could be considered. I only listed a few here, the main ones being your quad muscles as well as the rectus femoris and some of the glutes. That's not an exhaustive list, but these are kind of the main ones you want to consider for referring pain to this region. Also, you want to rule out other knee pathologies, OA, ligamentous injuries, meniscus, joint capsules, those sorts of things. Then also consider any ankle or foot pathology as a cause for anterior knee pain. And this will also play a role in what's happening at the knee if there's any dysfunction at the ankle or the foot. A good way to rule out referred pain to the knee, especially from the lumbar spine, is perform a thorough lower quarter screening. including, as the test you see here in the picture, a quadrant test for the lumbar spine. All right, so I'm going to pass it to Stephanie. She's going to review the literature with you.
So what does the literature have to tell us about how to treat patellofemoral pain syndrome? Well, typically, as Andy alluded to, the common presentation when you're assessing this condition could be one or several of these things, but you will typically see an adducted hip position, internal rotation at the hip, increased knee valgus, tibia will be externally rotated, sometimes excessive pronation at the forefoot or increased eversion at the heel. Good ways to assess these biomechanical abnormalities would be some functional testing, including squatting, single leg squat, stepping down. If you have an athlete, you could have them do quick deceleration and watch for these things. A gait analysis would be good as well with an athlete looking at walking or running on a treadmill. Single leg stance or single limb, single hop test are just a few that you could do. So overall, in the most recent systematic review and meta-analysis that we have on this condition, basically all they could say with confidence was that exercise intervention is superior to no intervention, which is something we run across a lot in our literature. However, there are some articles that we will be covering in just a few minutes that do go into a little more detail than just exercise. So specifically, which exercises can we choose? And the best quality evidence that we have would be level 2B or 6 to 8 on the Pedro scale. One thing that is true across the board is addressing hip strengthening with these patients. There's a few studies to suggest looking at rotator and abductor strengthening as well as quad strengthening. They found that to be superior to quad strengthening alone with these folks. Also, an article to suggest that rotator and abductor strengthening combined with core and trunk motor control activities, again, superior to just quad strengthening alone. They also performed a study where they just did hip strengthening alone before addressing any quadricep strengthening or closed chain activities. And they did this, I believe, for a period of 4 weeks. And they found once they started adding in the other activities, they saw much greater improvement in these particular females with patellofemoral pain syndrome. Also, they looked at Q angle in elite athletes, and they found just specific weight-bearing exercises. They went into a little more detail, but your basic quad, hamstring, and then also pulling in the hips strengthening activities did help to actually improve the Q angle itself. And then also looking at some feedback mechanisms and mirror retraining when you're treadmill running with these patients, especially patients with faulty mechanics leading to PFPS, that it does seem to really help. So that was some review, especially in that last article was a review from the Ortho Summit that we had this summer. And this was an article that Alexis Wright shared with us, actually a series of articles where they did some testing to determine which exercises specifically isolate the glute med and the glute max, or not necessarily isolate, but produce the best maximum voluntary isometric contraction. So you can see some good things to integrate with your patients that may present with this here. You can see some of the typical ones that we go to as therapists sometimes looking at like clamshells maybe would not be as good as, for example, the side plank abduction with dominant leg on bottom. So if you're treating an athlete, in other words, it may be, you may need to look a little bit further with your exercise decisions based on the literature. But as far as taping, which is a typical intervention used for these folks, or even using orthotics to correct if pronation is deemed to be one of the problems at the ankle. There's not really a whole lot of evidence to support these interventions, but using what we've learned, in the residency, test, treating, retesting, then we can see if these methods will help our individual patients as all the other methods that we discussed. So basically from the literature, the big takeaway for managing this condition is to definitely look at the hips, focus on strengthening there in addition to what you're doing at the knee and the ankle, the core, and elsewhere. So here are our references. Thank you all for your time.